Hello everyone, my name is Daltro. I'm a Brazilian obstetrician and gynecologist. I'm here with you today to present our systematic review on puberty suppression with GnRH analogues in adolescents with gender incongruity. For a little context, it is known that pubertal development of the gender assigned at birth can be very distressing for gender incongruent children and adolescents. So the American Society of Endocrinology recommends puberty suppression with gonadotrophin-releasing hormones analogues as early as tenor stage 2 for both transgender boys and girls, followed by puberty induction, usually considered after 16 years of age. Conditions for this approach include a confirmed gender incongruency, usually accessed by a multidisciplinary team with assured follow-up and, of course, patients' mature and free consent. Yet, we actually do not have that much substantial data on GnRH analogues when used for puberty suppression on gender incongruity. We do have data on puberty suppression with GnRH analogues on precocious puberty. This has raised some concerns over the efficacy, associated risks, and side effects of this therapy. The reason our team found it important to systematically review this issue. Our main objectives were to discuss the existing evidence regarding the use of gonadotrophin-releasing hormones analogues to block pubertal development in young patients with gender incongruity, and to analyze the outcomes of this therapy in organic, social, and psychological aspects. Our methods were in accordance with the parameters established by the PRISMA method for systematic review, and our keywords are listed below. The articles found were from 2009 to 2019, and even though we did not set any restrictions for a language, we only found articles written in English. Electronic search was performed by two different researchers in the PubMed Medline and Embase databases by the end of 2019. We removed the records found in duplication, and after that removal, we ended up with 108 articles, 86 of which were excluded due to being literature or systematic reviews, series of cases, guidelines, summaries, and comments. This left us with 22 full text articles that were read in full and accessed for eligibility. 11 of those were excluded by trail of theme. So 11 studies were included in this revision. From these 11 studies, we extracted design, sample size, study context, targeted subjects of intervention, outcome measures, and results. It was unfortunately not possible for us to use formal meta-analytic strategies due to the huge heterogeneity of the included studies. We opted to perform a narrative synthesis of the studies then, separating them according to the targeted subjects of the intervention. Beginning with efficacy and safety. In 2015, Shagan retrospectively studied the usage of triptorelin in adolescents with gender incongruity throughout a period of 3 months up to 3 years of therapy. They evaluated the dosages of luteinizing hormone, follicle-stimulating hormone, testosterone, estradiol, together with both liver enzymes, liver function, and renal function. The monitoring was done at the day 0 of treatment, 3 months after that, 6 months after that, and then every 6 months. Gonadotropins decreased in the first 3 months of treatment and did not change from that point onward, with the same pattern observed with estradiol and testosterone. But they observed slightly higher estrogen levels in young transsexual men who were in tennis stages 4 or 5 at the beginning of the treatment, compared to those who were in 2 or 3. However, these higher levels of estradiol were not associated with clinical signs of insufficient suppression, such as breast development or uterine bleeding. Monitoring of liver enzymes and renal function did not identify any changes or complications throughout the whole treatment. They even proposed that laboratory surveillance is not necessary during puberty suppression using triptorelin. There was another study published in 2014, a retrospective descriptive study with 84 young transgenders, 27 of which were in usage of GnRH analogues for puberty suppression. They collected data on characteristics, clinical management, and response of the treatment. Some side effects that were observed in this study were emotional liability, that even led to one discontinuation of treatment in one case of aseptic abscesses, another one of lower limb pain and headaches, and in one subject they observed a weight gain of 19 kilograms in 9 months. Those described side effects were all in male transgender. In addition to efficacy and safety, this same article evaluated the psychological aspects of the patients. It identified that 12% of the studied patients had already attempted suicide at least once before being checked into a hospital, compared to 5% of suicide attempts after follow-up or monitoring started. Anxiety was a very common comorbidity, affecting 44% of the transgender men and 19% of transgender women. In 4 other studies evaluated psychological aspects, and their general findings are listed here. We know that transgender youth in general has an increased risk for mental disorders. One study interviewed adult transgender women, asking their opinion on puberty suppression before gender-affirming hormonal therapy. They asked their expectations, and they answered that had they undergone this treatment before, they think they would have achieved physical changes closer to their personal goals. But they also said that this would not have any influence or change their ideas of their own gender identities. This is interesting because in 2011, another prospective study with 70 adolescents was conducted using several scales, including psychosocial functioning scales and body image scales. These were used to assess gender incongruency and the mental health of these adolescents. The use of GnRH analogues was associated with a significant improvement in the parameters of mental health patients without any influence on gender incongruency. This is in consonance with the other study we talked about, with the expectations of the women studied before. We also found that psychological support in conjunction with GnRH analogues therapy positively influence the psychosocial functioning of these adolescents, both together and separate. Despite the positive results that we just talked about related to psychosocial functioning, a control group for comparison was not established in any of those studies. And since the aging process alone is already related to increasing well-being in general, it's not possible to establish to which extent this improvement is related to the natural maturation of adolescents or the therapies evaluated in the studies. We know that the end of puberty is an important phase of bone mass accumulation, and that puberty blockage with gonadotrophin-releasing hormones analogues will leave the adolescents temporarily under sex steroid deprivation. Therefore, bone mass density was also a common subject of the selected studies. A prospective observational study published in 2015 accessed 19 trans male and 16 trans female in treatment with analogues, followed by gender-affirming hormonal therapy, re-evaluating their bone mass density when they completed 22 years old. So two studies by the same group, the one published in 2013 and the one published in 2015, they showed the same trend, where bone mass density would decrease during the analog phase of the treatment, but would recover after the beginning of the gender-affirming hormonal therapy, with lower z-scores at 22 years old than they had than the pretreatment ones. So they never recover to the same z-score they had pre-treatment. It is important to notice that the bone properties of transgender population differs from their age cisgender matched controls, and this data is consistent with currently available literature, making these outcomes a little harder to evaluate. In one of the studies, between the start of analogues and the age of 22 years old, the BMD z-scores compared with cisgender men in trans women decreased significantly from minus 0.8 to minus 1.4, and in trans men there was a trend for decrease, not statistically significant as in trans women, but there was a trend for a decrease from 0.2 to minus 0.3. The studies conclude that monitoring of the bone mass development in the population is warranted. Another similar study published in 2017 using triptorelin as puberty blockage, followed by gender-affirming hormonal therapy, assessed bone remodeling markers and aberrant bone mineral density. They found a decrease in bone remodeling markers during the use of analogues, showing a decrease in the bone turnover with stable bone mineral density. But as their peers would be in the same age increasing bone mineral density, their adolescents, these caused lower z-scores on the study subjects during the puberty blockage. However, after 12 to 24 months of gender-affirming therapy, apparent bone mineral density increased significantly, with the z-scores returning to normal in both transgender women and men. Again, normal, but not reaching exactly their pre-treatment z-scores, the z-scores they had before. Of body structure, Claver published a retrospective study of 16 years of monitoring adolescents with gender incongruity and its impacts on body fat, lean mass, and waist-hip index. They again used GnRH analogues followed by gender-affirming hormonal therapy. In the transgender girls, they observed increase in body fat percentage associated with a decline in their lean mass and waist-hip index. With transgender boys, the effect was the opposite. They used a re-evaluation at 22 years old. So they reevaluated those patients at 22 years old, and the structure and body composition of these now transgender women was more similar to cis women than cis men of the same age group. As for the now transgender men, they presented measures that varied between the references for cis men and cis women, in the middle of those references of the same age group. Those results were similar regardless of the tenor stage where they started on treatment, but early treatment seemed to be associated with a more distinct resemblance of the body shape to their assigned sex, especially for transgender boys, but with a similar trend for trans women as well. As limitations for our systematic review, very few complete and science-based guidelines are available for us, making further conclusions difficult. And studies found are very, very different, very heterogeneous, different definitions, population, and evaluation techniques, and sometimes they are based on small sample sizes, restricting statistical power. Even fewer studies assess long-term consequences of puberty blockage, most of the studies being short-termed. The association of puberty suppression with gonadotrophin releasing hormone analogues with other therapies, psychological therapy or gender-affirming hormonal therapy, these association can also be a confounding bias because we're not allowed to assess the specific effects of puberty blockage. That being said, there are though new publications after this review was performed, and we hope to be able to access new findings on safety and efficacy, possible side effects, especially on bone mineral density that has been proved to be a main concern, and possibly longer term studies with harder endpoints and more statistical power, allowing us to provide better counseling to our patients. I'd like to thank you all very much for taking time to attend this presentation. And before I take any questions, I would like to leave you with a picture of our team at Hospital Israelita Albert Einstein in São Paulo, Brazil. And I would like to leave you also with something to think about. This is a quote from Brazilian educator and philosopher Paulo Freire. Education does not change the world. Education changes people, and people change the world. My contact information is down below. And again, thank you very much.